If you heat human tissue to like exactly 45 degrees Celsius, you don't burn it, you actually wake it up.
Right. It triggers this massive biological emergency response.
Exactly. It forces the body to build entirely new structural scaffolding. And today, we're looking at what happens when you combine that precise thermal trigger with a highly concentrated serum of your own blood.
Which is an incredible concept.
It really is. So welcome to another deep dive. Today we're taking you through a stack of clinical compendiums, a major systematic review from plastic and reconstructive surgery, and current practice guidelines concerning intimate women's health.
And our mission for you today is incredibly specific. We're dissecting the clinical data on 2 regenerative therapies. So that's the O-shot, which utilizes platelet-rich plasma, and a non-ablative Erbium.YAG vaginal laser series.
We aren't just stopping at what they accomplish individually, right?
No, not at all. The data we are parsing is really focused on uncovering the optimal sequencing timeline when you combine them.
Because for anyone looking into non-surgical intimate wellness, these 2 treatments are just constantly paired. But, I mean, timing is the ultimate variable in biology.
It dictates everything.
Right. So do you prime the tissue beforehand? Do you sequence them on the exact same day? Okay, let's unpack this. Because the science of how these 2 modalities interact requires looking closely at the cellular mechanics of each.
Yeah, before we can map out when to combine these treatments for you, we absolutely need to establish the baseline of how they act on the tissue.
We have to look at the exact physiological mechanisms.
Exactly. Let's start with the laser, specifically the Erbium.YAG laser, like the Photona Smooth system referenced throughout our sources.
Right, so the Erbium.YAG operates in a 2940 nanometer wavelength. And from a physics standpoint, that specific number really matters because it aligns almost perfectly with the peak absorption curve of water.
Yes.
And since vaginal mucosa is heavily water dense, the laser's energy doesn't just like scatter into deeper pelvic organs. It gets trapped right in that superficial layer.
It targets a very specific depth of about 100 micrometers. But what makes the modern application of this laser so unique is its pulse dynamic.
The smooth mode.
Right, what's referred to in the literature as smooth mode. Instead of delivering a single massive blast of energy that would ablate or, vaporize the tissue.
Which would be bad.
Very bad. Instead, it delivers a fast sequence of low-fluence micropulses.
So it's basically stacking the heat. You're heating the tissue, letting it rest for a fraction of a millisecond to prevent ablation, and then heating it again to maintain a specific thermal threshold.
You're pushing the mucosal tissue to a controlled temperature of roughly 40 to 45 degrees Celsius, and that temperature range is a precise biological trigger for heat shock proteins, specifically HSP70 and HSP47.
And HSP47 acts as a molecular chaperone, right?
It does.
It specifically binds to newly synthesized collagen to ensure it folds correctly. So the heat stresses the tissue just enough to initiate this massive inflammatory and proliferative cascade.
Which means the body responds via neocollagenesis. That's the creation of tightly woven collagen fibers, which fundamentally changes the structural integrity and elasticity of the vaginal canal.
But that is only the first half of the equation. That's the structural remodeling.
Right. The second half is the O-shot, the platelet-rich plasma, or PRP. You take a sample of the patient's blood and spin it in a centrifuge to isolate that highly concentrated plasma.
And when that's injected into the clitoris and the interior vaginal walls, those platelets undergo degranulation.
Exactly. They open up and release their alpha granules right into the surrounding tissue.
And this is where we see a concentrated flood of physiological growth factors like PDGF, VEGF, EGF, and TGF-beta.
And their specific mechanical functions are what make PRP so potent here. Take VEGF, for instance, vascular endothelial growth factor.
Right.
It actively signals endothelial cells to migrate, divide, and form new capillary sprouts.
So it's building new blood vessels.
Yes, this neoangiogenesis restores the vascular network. Meanwhile, the other growth factors stimulate nerve regeneration and deeply hydrate the extracellular matrix.
So, if we look at this mechanically, it's not unlike a construction site.
I like that.
Like, if the vaginal tissue is a garden, the Erbium.YAG laser is like aerating the soil, creating strategic microstress to wake things up. And the O-shot is like pouring in premium biologically customized fertilizer.
That analogy hits the mechanism perfectly.
But let me push back a bit. If both treatments ultimately aim to build collagen and improve blood flow, isn't doing both redundant? Like, why do you need both?
Well, what's fascinating here is that they aren't redundant therapies at all. They're enabling each other. It's a multiplier effect.
Oh, wow.
Yeah, you're supplying the blueprint with the laser and handing the biological site the exact raw materials required to execute it with the O-shot.
Okay, but that raises a massive logistical problem.
Yeah.
If the PRP needs a healthy, robust blood supply to integrate optimally, but the patient's coming in specifically because they lack a healthy blood supply or structural integrity, how do you bridge that gap?
Right.
You can't just pour concrete onto a crumbling foundation and expect it to hold.
You really can't. And that is the exact clinical hurdle that brings us to the first sequencing strategy in our sources.
The primer strategy.
Yes. Moving through the clinical data, we see this primer strategy. In one specific clinical study protocol we reviewed, patients actually received their PRP injections exactly 14 days prior to beginning a 2-session series of non-ablative Erbium.YAG laser treatment.
Utilizing the Renovolase protocol.
Sad.
14 days. Let's look at why that specific window exists. It traces back to the timeline of neoangiogenesis, doesn't it?
It does, because VEGF doesn't build new blood highways overnight. It takes time for those endothelial cells to proliferate and assemble.
So by injecting the PRP a full 2 weeks prior, you are changing the biological baseline of the tissue.
Yes, so by the time the patient arrives for their very first laser session, the vaginal mucosa is already highly vascularized. It's metabolically active and flushed with a new blood supply.
But if I'm looking at this from, like, a clinical efficiency standpoint, adding a 2-week lead time to an already multi-month process seems inherently cumbersome.
It is a commitment, for sure.
For an average patient seeking regenerative treatments, does this primer method actually yield a statistically better end result? Or is it just testing my patience?
Well, it comes entirely down to the patient's baseline cellular health. For a patient with relatively healthy tissue looking for mild tightening or optimization, this 14-day primer might be completely unnecessary.
But what about patients suffering from severe genitourinary syndrome of menopause, or GSM?
That's where it changes. In severe GSM, you're dealing with tissue that is highly compromised.
It's physically thinned out, it lacks hydration, and the vascular bed is practically non-existent.
Exactly. If you take tissue in that compromised vascular state and hit it with a 45-degree thermal laser right out of the gate, you lack the capillary network needed to properly dissipate that heat.
Oh, so instead of triggering a healthy remodeling response, you risk overwhelming the tissue.
Yes. The thermal shock could potentially outpace the tissue's ability to heal.
So the 2-week PRP primer acts as a metabolic heat sink. It fortifies the tissue, ensuring it has the vascular resources and hydration to handle the laser's thermal stress and actually remodel, rather than just sustaining damage.
It's a calculated biological shield. You are upgrading the tissue's defense mechanisms before you introduce the stressor.
But as we pointed out, the 14-day wait introduces a lot of friction into the treatment timeline.
It does, and the data shows that the vast majority of patients don't have tissue so severely compromised that it requires this primer. Which brings us to the second highly prevalent sequencing timeline in our sources.
The concurrent protocol.
Right, combining them on the exact same day.
The sources often refer to this as the laser-enhanced O-shot. And the sequencing order here is pretty rigid. The patient undergoes the Erbium.YAG laser session first.
Yes, the non-ablative laser treats the entire vaginal canal. Then, immediately following the conclusion of the laser application, the O-shot is administered.
So it's injected into the clitoris and the anterior vaginal walls, but additionally the remaining PRP is applied topically.
Smeared directly onto the freshly resurfaced vaginal mucosa, yes.
Wait, let's scrutinize that protocol for a second.
Right.
We just established that the laser heated the lamina propria to 45 degrees Celsius to stress the collagen.
Right.
If you take delicate PRP proteins and growth factors and inject or smear them right into a thermally stressed, heated environment, how do they survive?
It sounds counterintuitive.
Yeah, I mean, thermal denaturation of proteins is a real concern. Aren't you essentially cooking the PRP before it can even degranulate?
That's the exact pushback you should have on looking at this. But if we connect this to the bigger picture, the timing here is a beautifully orchestrated biological dance. We have to look closer at the thermal relaxation time of the tissue.
Which is the rate at which the tissue sheds the heat.
Precisely. The laser hits 45 degrees in those micropulses, but the tissue surface cools rapidly once the laser is removed.
Oh, okay. So by the time the provider transitions from the laser to administering the PRP, the surface temperature has already dropped.
Yes, it drops below the denaturation threshold for those specific growth factors very quickly.
Okay, so the heat dissipates enough to keep the proteins intact. But what about absorption? If the surface isn't ablated, How is topically applied PRP penetrating deep enough to do anything useful?
Because while the temperature drops, the structural changes remain. The Erbium.YAG laser in smooth mode doesn't vaporize the epithelium, but that thermal energy alters the tissue dynamically, leaving it highly permeable for a short window.
It creates these invisible, thermally modified microchannels. The heat essentially forces the cellular junctions to become temporarily porous.
Yes. So when you apply the PRP immediately after, those growth factors don't just pool on the surface, they sink deeply and rapidly into those microchannels, penetrating straight down into the lamina propria.
That is the exact depth where the fibroblasts live and where the neocollagenesis needs to happen.
It's an engineered delivery system. You're using the laser not just as a thermal trigger, but as a permeability tool to bypass the epithelial barrier without actually cutting it.
That's brilliant.
And the concurrent application serves a massive secondary purpose regarding patient recovery. Because the PRP is instantly absorbed into this stressed tissue, it acts as an immediate biological band-aid.
Right, because the standard inflammatory response to a vaginal laser session usually involves like 24 to 48 hours of mild swelling or erythema.
But PRP is loaded with anti-inflammatory cytokines, so applying it directly into those microchannels essentially overrides that initial inflammatory spike. It soothes the tissue and dramatically accelerates the immediate recovery timeline.
So we have the micro timing clearly laid out. You either prime 14 days prior for compromised tissue, or you utilize the concurrent protocol for an enhanced rapid recovery effect.
Exactly.
But to understand the full scope of this data, we have to zoom out. We need to map out how this fits into the macro timeline of a full regenerative series.
Because none of this happens in a single isolated visit. These therapies operate on different peak schedules. Let's look at the laser schedule first.
The clinical data makes it clear that the Erbium-YAG laser is not a one-time procedure. To achieve sustained neocollagenesis and structural remodeling, a standard clinical course requires 3 distinct laser sessions.
And those sessions are strictly spaced, usually 4 to 6 weeks apart, averaging around 30 days.
You have to give the fibroblasts time to actually synthesize the collagen in response to the heat shock proteins before you introduce the next thermal signal.
Exactly.
So the laser operates on a 90-day arc with a pulsing thermal stress every 30 days. But the OSHOT schedule is operating on an entirely different biological clock.
It is. According to the sources, when a patient receives an OSHOT, it takes 4 to 6 weeks just to observe the initial cellular responses.
And the neoangiogenesis and nerve regeneration continue to build, steadily compounding until they peak around the 3 to 4 month mark.
You have 2 totally divergent timelines. The laser is an episodic monthly intervention. The PRP is a slow, continuous metabolic climb to a peak at month 3.
Here's where it gets really interesting. If we overlay those 2 schedules mathematically, we run into this puzzle. How do you synchronize a monthly intervention with a 3-month continuous climb?
Right.
Since the OSHOT takes 3 months to reach its maximum physiological output, the optimal sequence is to perform the concurrent laser-enhanced OSHOT during the first or the second laser session.
Let's trace the physiology of that sequence. If you receive the concurrent protocol on visit number 1, your tissue is immediately flooded with growth factors. 30 days later, you return for laser session number 2.
And by this point, the initial VEGF from the PRP has had a month to stimulate new capillary growth.
Yes. Your tissue is now significantly more vascularized than it was on day 1.
Making it highly responsive to the second thermal signal. And then, 30 days after that, you arrive for the third and final laser session.
And right at that exact juncture, roughly 60 to 90 days after the initial PLP injection, the OSHOT is reaching its absolute biological apex of neoangiogenesis.
You're striking the tissue at its absolute healthiest, most hydrated, and most blood-rich state. By stacking the regenerative peaks this way, you exponentially maximize the efficacy of that final laser treatment.
You're leveraging the peak biological output of the PRP to handle the final thermal stress.
That makes perfect logistical sense when you map out the biology. But when we look at the clinical practice guidelines, specifically the recent publications from the American Urogynecologic Society, or AUGS,
we hit a notable roadblock in the consensus.
we do. AUGS practice guidelines regarding energy-based devices are notoriously conservative, and for good reason.
They note that while synergistic therapy, combining these lasers with biologicals like PRP, is highly beneficial in clinical observation, the absolute universally ideal sequencing protocol remains officially unknown by major medical bodies.
So despite the biological logic we just traced out, there is no universally mandated sequence written into the medical doctrine. Why is there such hesitation to declare a gold standard timeline?
Well, it comes down to the variables inherent in regenerative medicine. First, you're dealing with autologous treatments. Every single patient's PRP has a different baseline concentration of platelets and growth factors.
Right.
Second, you have immense variability in device parameters, different fluence levels, different pulse durations. To establish a universal medical doctrine, AUGS requires large-scale, randomized controlled trials comparing these exact sequencing timelines head-to-head.
And in the rapidly evolving field of biologics, those longitudinal, multivariable studies are incredibly difficult to standardize.
Which means the protocol isn't a rigid law, it has to be a customized strategy.
A skilled clinician has to evaluate the specific baseline platelet count, the severity of the tissue atrophy, and the patient's biological response rate.
Yes, to determine if they require the 14-day primer or if they can leverage the same-day concurrent protocol to stack those 3-month peaks.
It demands a high level of clinical intuition. You are actively managing the body's healing mechanics in real time.
Exactly.
So, summarizing the data for you as you navigate these options, the science shows us that combining these modalities creates a profound multiplier effect.
The Erbium.YAG laser provides the thermal scaffolding and permeability, while the platelet-rich plasma provides the regenerative building blocks.
And while a 2-week primer is a highly effective strategy for fortifying compromised vascular tissue, the most prevalent and synergistic sequence found across the literature is the concurrent application.
Utilizing the laser to create those thermally modified microchannels and immediately following with PRP to act as a biological band-aid, deeply penetrating the lamina propria.
All integrated into a multi-month series to ensure the PRP's regenerative peak aligns perfectly with the final thermal laser session.
It is a masterful manipulation of human cellular mechanics. But as we synthesize this data, there is one fascinating variable buried deep in the clinical FAQs of our sources.
Oh, yeah.
A variable that researchers are only just beginning to quantify.
And it throws an entirely new metric into the equation.
We spent a lot of time analyzing how the Erbium YAG laser changes the physical structure of the tissue and how it alters local temperature. But what about the chemical environment, specifically the pH?
The acidity or alkalinity of the vaginal canal. We know the natural vaginal environment is highly acidic, usually sitting between a pH of 3.8 and 4.5.
Yes, but here is the critical physiological intersection. Hematological data dictates that the stability of PRP and the precise release rate of its alpha granules are highly dependent on the pH of the environment they are placed in.
Okay, so
Platelet degranulation is theoretically optimized closer to a physiological pH of 7.4.
wow, so you have a highly acidic environment receiving a biological compound that prefers a neutral environment.
Exactly. Now, consider the thermal stress of the laser. Does the application of 45-degree heat and the resulting immediate inflammatory cascade temporarily alter the local tissue pH in those crucial 10 minutes following a laser session?
If the thermal energy shifts the local pH even slightly, it could fundamentally alter the release kinetics of the growth factors you're applying.
It raises a monumental question for the future of the sequencing. Is it just the microchannels and the temperature that make the concurrent protocol so effective? Or does the exact thermal and chemical environment of the vagina in those specific 10 minutes unlock a supercharged degranulation of the platelets?
Could the pH shift be the hidden biological key, regulating this entire synergistic process?
It's something to think about.
It suggests that there is an entire microenvironment of chemical variables we haven't even begun to optimize yet. It is a frontier of regenerative medicine that proves just how much we are still discovering about the intersection of thermal physics and human biology.